Thank you very much, Dr. Farmer. It's going to be my pleasure to introduce Dr. Ruth Shim. Before I introduce her, it's very exciting that she will be kicking off our summer/fall launch of our Succeed program, professional development didactic series. As you all know, for the last couple years, we've been blessed to have wonderful thought leaders around UC Davis to come and talk to not just our faculty, but also our trainees and staff on different topics to help with professional development. Today, Dr. Shim will talk about structural racism in medicine. And you all will see this list of the different topics throughout the year. In November, beginning in January, social media and academic communication. February, how to be a great peer reviewer by Dr. Brown. Marketing yourself by Dr. Campbell. Building successful teams by Dr. Raff. Providing meaningful feedback by Dr. Fan. And this is Dr. Young requested that this be his title, Exiled into Retirement. That wasn't my idea, but it will talk about discussions on transitions to retirement. Also, throughout the year for wellness and well-being, we will have a return of our 30-minute mindfulness moments on Friday by Dr. Vivian Roseby. And this is a meditation mindfulness activity that was very popular last year. And finally, in October and November, we will have a return of the faculty chats with the chair. So we'll have two sessions because there'll be video conferencing with early career and volunteer clinical faculty, and a session in December rather, with mid-career faculty. Because we've noticed that the senior faculty are always in Dr. Farmer's office complaining, and so they get a lot of face time with Dr. Farmer. But that may not be the case for the junior faculty and the mid-career faculty, especially the Gen X folks who never complain. So it's good for them to get face time and have unfettered conversation with Dr. Farmer and express their wishes and concerns and thoughts. But today we'll start off with our Succeed Program Grand Rounds, featuring Dr. Ruth Shim on her title, Dismantling Structural Racism in Medicine, Challenges and Opportunities. Dr. Shim is holder of the Luke and Grace Kim Professorship in Cultural Psychiatry in the Department of Psychiatry and Behavioral Sciences at UC Davis. She is Professor of Clinical Psychiatry, Director of Cultural Psychiatry, and Chair of the Vice Chancellor's Advisory Committee on Faculty Excellence and Diversity here at UC Davis Health. She received her MPH in Health Policy from the Rollins School of Public Health at Emory University and an MD from Emory University School of Medicine. She is a member of the Board of Trustees of the Robert Wood Johnson Foundation and American Association for Community Psychiatry. She serves on the editorial boards of the Psychiatric Services, Community Mental Health Journal, and American Psychiatric Publishing, and is co-editor of the book, The Social Determinants of Mental Health, and the upcoming book, Social Injustice in Mental Health, to be published in early 2021. She is an at-large member of the National Academies of Sciences, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders. Dr. Shim's research focuses on mental health disparities and inequities, and she provides clinical psychiatric care in the UC Davis Early Diagnosis and Prevention Treatment Clinic, otherwise known as EDAPT. Without further ado, Dr. Shim.
So I'm really happy to be here. I don't often talk to surgeons, so it's really nice to see you all and to be in this space today. I think that I've done my best to try to apply the work that we are doing in medicine to surgery, and so I'm going to spend a little bit of time doing that. But I will just say that we're going to go over our learning objectives, of course, and then I always start talks about structural racism with a disclosure and a disclaimer. Then we'll spend a little bit of time going over some key concepts. We'll do a very quick literature review, and finally some plans for the future. So we are going to talk about key concepts associated with structural racism in medicine. We're going to evaluate the evidence base related to structural racism and surgical outcomes, and we're going to identify solutions to dismantle structural racism in medicine. So as I said, I always start talks with a disclosure and a disclaimer. My disclosures are that I really don't have any disclosures, and I don't work for any drug companies or anything like that. So I don't usually have any disclosures to make, but I actually have to usually make a lot of disclaimers when we start a conversation like this. So the first is that whenever you talk about race or whenever you talk about racism, we have to acknowledge that it's a difficult and it's an uncomfortable topic, and that there are complex feelings that emerge, including guilt, anger, resentment, defensiveness. You may actually perceive that I am calling you racist or sexist or any number of things. You may feel that I have some sort of political agenda. You may think that I lack objectivity. These are all things that I've been accused of before when talking about these things. So I feel the need to just lay it out there before we start talking about this stuff. And some of the reasons why, when we start talking about these things, these emotions come up is because we have been socialized to believe that it's not polite to talk about race. This starts when we're really young as kids, and it continues on. And particularly physicians have not been taught about the connection between racism and health. And medical school has a long storied history and tradition of teaching about biological determinism, which I'll talk a little bit more about. It's the way that I was taught when I attended medical school. It's the way most of everyone who attended medical school was also taught. And perhaps recently, in the last several months or so, we might say, oh, the times are a-changin'. We're not really dealing with these problems in the same way. We have a certain awareness now. But in that space, I will just point out that some people do feel like there has been an overemphasis at this point, and maybe even an overcorrection for the discussion that we're about to have. So I know you all are saying, okay, you did your little disclaimer, but I'm not going to feel any of those things, so it doesn't really matter. But I just want to give you an example. A couple years ago, I was giving a talk on prevention and mental health. And when I got my evaluations back, this was the feedback that I got. Preventions which attempt to decenter whiteness have no place in a medical conference. Such presentations are better given to the neo-Marxist whitey haters found at university deconstructionist courses heavily populated by angry women and dissent minorities. So you're saying you may not have a response, but people sometimes have a response. I didn't talk about racism in that talk. I actually didn't mention the word. So sometimes people have a reaction. Okay. So the last thing I'm going to say about that is that James Baldwin often talks very eloquently about racism. And so because these emotions stir up guilt, stir up all these complex feelings, I just want to keep this quote in the back of your mind. I'm not interested in anybody's guilt. Guilt is a luxury we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I'm a man and a citizen of this country, and you are responsible for it for the very same reason. So if you start to feel some emotions, use that time, and I recognize I'm talking to surgeons, but use that time to do a little bit of self-reflection and turn inward and say, why am I feeling this feeling right now? Just take a minute to kind of do a little self-reflection. Okay. Done. My disclaimer is done, so let's talk about some key concepts. I'm going to go through some definitions because I think it's really important for all of us to be on the same page when we talk about these things. The first thing that I want to talk about are the social determinants of health. And this is the conceptualization of the social determinants of mental health. And we all know what the social determinants of health are. They are the things about where we live, work, age, play that affect our health and have an impact on our health. So this is the conceptualization that my colleague and I, Michael Compton, came up with when thinking about how this affects mental health. But it applies to physical health as well, because there's actually really no difference between physical and mental health. So at the bottom, you see that public policies and social norms are really driving what ends up being an unjust distribution of opportunity and an unjust distribution of advantages. And then those policies and norms, which we'll talk a little bit more about later, lead to that inequity and what we call social injustice. And then that leads to a host of social determinants of health. And that includes things like adverse childhood experiences, low education, homelessness, housing, and housing instability, adverse features of the built environment, and particularly racism and discrimination. All of those things then lead to a bunch of risk factors, things like behavioral risk factors, biological risk factors, choices that people make, decisions that they make about their health, whether they choose to smoke, whether they choose to use drugs, all of those types of things. And then those things lead to poor and adverse health outcomes and mental health outcomes in particular. So I'm going to talk a little bit more about the issue, and I think, again, very relevant to surgeons. It's very clear that if you try to intervene at the very top of this pyramid here, if you're intervening at the level of the risk factor, you've pretty much intervened too late at that point, because at that point the disease has already set in, it's already done its damage, and so there's very little that you can do. You do your best, but really we're talking about how do you move further upstream and down this pyramid, and that's what we're thinking about. So we all know what health disparities are. Health disparities are the differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or where you live. So these are all of the things that lead to differences in health outcomes in different populations. Doesn't really matter what the population is, there's just differences. That's health disparities. Health inequities, however, are a little bit different. Health inequities are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So there's a specific difference between these two definitions when we look at them. One is basically saying it's a difference, and it's not really saying much about what that difference is. The other one is saying there's a difference that's specifically the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. This becomes really relevant when we start to, what we're going to do in a minute, review the literature and look at what our outcomes are in surgery in particular, because we use this language, and particularly in the US, we use this language of health disparities, when most of the time we're actually talking about health inequities. It's not just that there's a difference. It's actually that the difference is driven by unjust social and economic policies and practices, and that's what leads to the difference in health. And this becomes a really fundamental concept, so I'm going to come back to that. If it's a difference that's just a biological difference, or if it's actually something to do with the policies and practices in our society. To get us thinking about that a little bit, here is a quote from a scientist by the name of Greer, who said, "African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less health care, more disease, lower life expectancy than whites. If you believe blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans." And I can't stress this quote enough, because I think that sometimes we naturally believe, or we're socialized to believe in this society, that maybe there is some sort of natural difference between certain groups of races. And so maybe it is in fact true that maybe blacks are naturally dumb, sick, and criminal, and maybe that's why we see these differences. And oftentimes when we look at differences in health outcomes, we often think maybe it must be something in that individual or in that group of individuals, in that cultural group, something about the ways that they think, the decisions that they make, those types of things that are leading to these differences, rather than looking at the institutional racism that provides a very practical and traceable explanation. And I just want to highlight this as it relates to COVID, because as we were looking at COVID-19 disparities, the Surgeon General of the United States talked about, when he first started bringing up the concept that there were differences in outcomes in COVID, he mentioned that that there were higher rates of infection and higher rates of mortality associated with Black and Latinx populations. And then he said, you have to do this for your big mama, for your abuela. He made some comments like that. And his point being is that the differences in these COVID-19 outcomes were people, Black people or Latinx people, not making good decisions about their health or not protecting themselves, rather than understanding that Black and Latinx people are more likely to be essential workers. They're more likely to be forced to be exposed to the risk of COVID than other populations. And so, like, that lack of fundamental understanding coming from the highest ranking government physician kind of implies the lack of understanding of these things. So a couple of other concepts. First, we have to understand that race is a social construct. It's really kind of ridiculous when you think about it. We do not know how to categorize race. We kind of make assumptions. Certain people's races some races are more potent than other races in some ways, and it just doesn't make sense. And if you start to kind of look at history, you begin to understand that race was socially constructed, it was created, that these categories were kind of falsely manufactured in order to advance oppression and marginalization of populations. The other thing is that you cannot accurately biologically categorize race, and it's for the same reasons. Because it's a social construct, you can't do a genetic test and determine somebody's race. You can't do any sort of like biological testing and make some sort of point. That being said, there's a lot of geneticists that believe that they can do these things. There's a lot of medical professionals that still seem to have some understanding of this, or still think that it's somehow biologically or genetically categorized. What it is, in fact, is a rough and imprecise proxy for culture, genetics, and socioeconomic status. So really, it is basically a marker for these other things. The problem is that the marker is a really imprecise marker. It doesn't do a good job, and in a field in which we value and heighten the idea of precision, it really doesn't make sense that we're using such a crude and imprecise marker. And yet, we use race to confirm our assumptions, our prejudices, and our biases about patients. So, just to define structural racism, it is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. And it's not something that a few people choose to practice. It's not something that just a couple institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems with which we all exist. And most importantly, it does not require the actions or intentions of others. So we can all be non-racist, we can all be anti-racist people, and still the structures that have been created will ensure that we continue to have structural racism, because it does not require our goodwill and our thoughts. So if I were to wave a magic wand and completely eliminate interpersonal discrimination today, that back and forth kind of racism that we hear most about, the one-on-one type of racism, we would still have racial and ethnic inequities in health due to the persistence of structural racism. So I did say we were going to do some concepts. I have a couple more concepts, and then I'm on to the literature, I promise. So a couple of things that are specifically related when we think about medicine. One is this idea of essentialism or biological essentialism. It's the idea that there are these distinct, unchanging natural characteristics that define social groups and facilitate their categorization. And I think that medicine and surgery often helps us we're taught to do this type of essentialism. We're taught to recognize patterns. We're taught to put things into categories. And so we have to be very careful, because the same thing that can actually help us be effective in our jobs will actually also can have the risk of leading to discrimination and racism. Another issue is erasure of context. And that's when you fail to consider the socio-historical context when seeking to understand the etiology of inequity. So when you're trying to say, why is there this difference? And we'll talk a little bit more about that. When you're trying to understand why is it that this group has worse outcomes compared to that group, if you haven't necessarily considered the historical context or the social context behind that, you can come to some very false assumptions and some very inaccurate associations. And then positionality and invisibility is when you fail to see or examine or question the unnamed norm. So in this country, the unnamed norm is white, heterosexual men. And so we often kind of look at that, and in fact, even when we get down to our research, oftentimes we have a reference group, or we have a group that we norm things against. And when you norm something against one group, and you don't look at that group with the same kind of lens of abnormality as you look at all of the other groups, that's when you're not thinking about your invisibility of positionality. And then biological determinism is the false belief that racial groups are biologically and genetically different. And again, I'm not here to say that anybody here believes in biological determinism. But I will say that I was taught subtly a model of biological determinism when I was in medical school by non-racist attendings and professors who were very well-meaning, who were taught in their medical schools by people who were not particularly racist, but that these things are so baked into the culture that we start to believe that there are these differences that occur biologically and genetically by race, even when they don't. Okay, so there's lots of different ways in which you can discriminate against people. We talk about structural racism, we talk about racism because it's the most salient. That's the thing that I'm focusing on because it's kind of top of mind right now. But I think it's important to remember that there are many, many different ways, and that there is the concept of intersectionality, that all of these concepts come together, and oftentimes no one, even as I just described heterosexual white men, even in that category, there are still groups and ways in which people can be discriminated against. And so kind of I guess I'm basically saying no one is free, no one is without risk of being discriminated against or mistreated. There's a lot of different types of discrimination. You can have legal discrimination, such as like Jim Crow laws in the past. Illegal discrimination, we have many laws on the books now that say you can't discriminate against people for certain reasons. There's overt, really obvious discrimination, and then there's covert. That's kind of like microaggressions, where you're kind of like, what just happened in that encounter? There's levels of discrimination. There can be interpersonal or individual, as we talked about, that one-on-one type that is the most common and the thing we think about the most. But then there's also institutional or an organization. UC Davis Health, for example, is an example. Or structural, which is kind of all of the systems in our society. Okay. I did say that I wasn't going to spend forever on key concepts, and I promise I'm going to be moving on in just a second, but I want to take a minute to talk about a couple of examples of how you see structural racism impacting health outcomes. The first one is residential segregation, and this is probably the most salient thing about how we see outcomes related to health. So because of redlining, because we have created a system in this country where neighborhoods are highly segregated, and then neighborhoods are invested in or disinvested in. And what you see, even if you look at maps of Sacramento, is where do we put our health systems, where do we put our clinics? They're not typically located in places where, in these highly segregated areas, or places where the majority of people are people of color. So that residential segregation then leads to people having problems accessing care. So it basically creates kind of a host of problems, right? Because the residential segregation also leads to high levels of unemployment. It also leads to problems around education and all of those things. But particularly where it relates to health is that people have difficulties accessing services. People live in areas like food deserts where they're not allowed to, or they don't have access to fresh foods. And those things kind of lead to this long decline in health outcomes for certain populations. And that's how you get to this whole concept of your zip code may be more important to your overall health than your genetic code. Immigration policy. This relates to the idea that we have structured our policies around immigration to ensure that we only admit people into this country that are relatively healthy. So typically, if you need a major surgical procedure, you're not going to be, approved for immigration in this country. Some people do try to come into the country for healthcare purposes, but certain policies are set up so certain populations are able to do that. Other populations are not really don't really have that ease. What you end up seeing as a result of this is a healthy immigrant effect, meaning that certain populations, the people that are immigrating to that country are healthier than the general population of that country. And then those healthier people, we in the United States look at that particular group of people and we say, wow, look at that group of people, they're healthier. And then we look at the people that are here in the country and we say, why did these people have all these illnesses and problems? And we're not really understanding how the immigration policy has kind of dictated who comes into the country and how healthy they are. And that's why we're seeing this effect. So if we go back to those countries, we'll see the same range of health inequities that we see in other countries, in this country. So the Social Security Act of 1935, this is that wonderful creation of retirement benefits, the idea that as you're aging, as you're getting ready to retire, you should not be worried about your financial situation. You should be able to pay into the system and get back a nice little stipend that you can live on. And then you can also pass that wealth on to future generations. You can give that money back to your children. So it was a really important bill, a really important act, because it led to improved health around mental health, and that wealth, that increase in funding led to people being able to live healthier lives. The problem is that Social Security Act, when it was passed in 1935, in order to get it passed, Southern senators stated that they had to exclude domestic and agricultural workers. And it just so happened that the majority of domestic and agricultural workers at the time were African American and were Latinx people. So they did not have that same opportunity to build that wealth, to get that Social Security benefit and pass that wealth on to their generations. That then led to kind of long-standing problems associated with health going forward for certain segments of the population. Healthcare is a huge one. We don't have time to go into all of it. We're going to touch on a couple of things, but the fact that we have a piecemeal health insurance system that's based on that's based on employment relates to, it is actually a structural racist issue. Because I don't have time to talk about it, I will encourage everybody who hasn't listened to the 1619 podcast on the episode on health to listen to that, because they really kind of lay out how that works. And then the war on drugs, we kind of know that very well. But I just want to highlight that when we think about it, we have two very different stances on what we consider to be criminal and what we consider to be public health. And so we often think about the opioid epidemic, and we're taking a very active public health approach to that. But we also have a cocaine epidemic in this country, and that has been seen much more as a criminal enterprise, and we've managed that not with public health interventions, but with incarceration. Okay, I think this is my last key concept. It is the idea of thinking about inequity versus justice. And so inequality is this idea that some people get more opportunities, some people have unequal access. Equality is the idea that you give everybody the same thing. You are being fair. You give everyone the same tools. you treat everyone the same. And once you do that, you should have the same outcome. But as you can see in this photo, it doesn't really work like that. Equity is the idea that people need different things, right? So in this system, you may need a different size ladder if you're trying to get to these apples, as you can see. And that is really a starting place, a really great goal. But I actually think we have to start moving towards this concept of justice, which is thinking about how do we fix the system to offer equal access to both the tools and opportunities. And that's when, if you fix the system and address the tree and the way the tree is unequal, then you don't even need to provide different tools because people are able to get what they need. Okay. So I mentioned COVID. I mentioned that you have these differences in outcomes. And I think that COVID, as horrible as it has been, finally solidified in people's minds that there are differences in health outcomes that are not biological or not related to essentialism or not related to biological determinism. That these outcomes and mortality aren't really related to the idea that there's fundamental difference between different racial groups. And so that, like riding on that, that increased knowledge and increased awareness, I think is a really important time for us to capitalize. But I do think we should look back and think about, how we've thought about things before and maybe how we think about things now. So this is from a study from 2013. It's not so long ago. But it was looking at the differences in health disparities and health outcomes in surgery. And the authors of this paper said that it is well known that there are significant racial disparities in health outcomes, including surgery. However, the mechanisms that lead to these disparities are not fully understood. And that was back in 2013. And so this particular article was trying to get at what the mechanisms are. Why do we have these disparities in health outcomes? And so we'll talk about that, but they identified a couple of these disparities, and you all know this material better than me. I would hope that you know this material better than me, but just a couple of examples include female gender being at increased odds for mortality among Black patients with lower extremity arterial disease. Black patients have higher rates of in-hospital complications or disease recurrence, lower rates of graft survival, and higher rates of limb loss than white patients. And larger disparities are noted in high-risk surgeries, particularly, for example, in a 2009 study on anterior cervical spine. And then you can see mortality rates for appendectomy, gastric fundoplication, and gastric bypass surgeries, much higher for Black patients than white patients. And also, among Medicare beneficiaries, Black patients were more likely to be readmitted after hospitalization than surgical patients, surgical procedures with white patients. And you can see that was statistically significant. So that was in 2013. In 2016, they did a survey of practicing general surgeon members of the American College of Surgeons and just asked, do you think that racial disparities exist in healthcare? And in that population of surgeons, 37% said that racial disparities existed. So just a little over a third believed that. And then when they asked, were there disparities happening in their own health systems, in their own hospitals and clinics? Less. So even the people that said that it happened said it wasn't happening in their systems. So less people agreed with that, and just over 20% thought that this had anything to do with them. And then that number gets down to 8% when you're asking, what about like your own practice? What are you doing? So I'm hoping if we were to do an informal poll today, that these numbers would look different than this. But I think there's a lot of awareness that is still not where it needs to be. And then I just want to highlight this data from the Robert Wood Johnson Foundation about discrimination when going to seek health care. So they asked, have you ever been personally discriminated against when going to a doctor or a health clinic? And you can see that, as I mentioned, there's lots of ways to be discriminated against. You can see that all racial groups that they surveyed reported some rates of discrimination when going to see a doctor. Men and women reported some discrimination, and LGBTQ people also reported discrimination. So When you go to seek care, it can lead to patients can perceive that they are discriminated against. And that, I think, has a huge impact that we don't really think about how people access care. Generally, I know in my personal experiences, when I'm discriminated against, I usually don't return to whatever that setting is. So if I go to a restaurant and I feel I've been discriminated against, and that's happened to me before, I don't go back to that restaurant. And so if a patient goes to seek health care and is discriminated against, I think it actually has a huge impact on how people access care going forward. I bring that up because we're going to talk about that in just a second. So the authors of that paper were wondering, what are the mechanisms? What are the contributing factors? And whenever we talk about contributing factors, we talk about patient factors, we talk about provider factors, and then we talk about systems level factors. And patient factors include socioeconomic status, insurance coverage, willingness to undergo surgery, and advanced presentation, disease burden, and comorbidities. Provider factors include the receipt and type of surgery, surgeon volume and quality. And I say implicit bias with a question mark because it wasn't brought up in this paper because the paper was much older. We now know and have enough data to support how implicit bias affects providers. But they, at the time when they created this paper, didn't know about all of that data. And then system factors include access, hospital volume, hospital patient population, lack of clinical trial enrollment for people of color. The point I'm trying to make with this slide is that I spent most of the early parts of my career looking at what are the things that cause disparities / inequities. And I spent a lot of time looking at the literature. And the literature, as you can see, looked very much like this. Long, long list of things that are patient factors, a medium-sized list of things that are provider factors, and a few things that are system factors. But when I look at this list now, and it's the same thing, again, I was looking at it from a mental health perspective, it's the same for all things in medicine. I actually see everything on this patient factor list as being a structurally racist cause. That these aren't individual patient factors, these are system level, structural level factors. For instance, socioeconomic status. We just kind of highlighted some of the reasons why you see differences in socioeconomic status related to residential segregation, related to discrimination and racism in employment, related to the Social Security Act of 1935. So socioeconomic status is not a patient factor, it's actually a structural factor. Insurance coverage. We talked about how the health insurance system and the lack of healthcare access is specifically a structurally racist concept. Again, 1619 describes it, but this is a system level factor. This is not a patient factor. Willingness to undergo surgery. So I just gave you the data on discrimination. I just talked to you about whether or not you would go to a place you were discriminated against. So again, this is listed as a patient level factor when it seems to me to at least be a provider level, probably much more of a systems level factor in that the health system has a responsibility to engender the trust of the people that are seeking their care. Advanced presentation, this is when people spend way too much time getting sick before they go see the doctor. Part of that has to do with how much trust you have in the care that you're receiving, but also it has to do with access. Again, these are structural issues. And then the disease burden and comorbidities, we've talked about how these disparities and inequities exist because of all of these other factors. So I actually think that I'm kind of done at this point in my career thinking about what are patient factors and what are provider factors because they're all driven by structural and systemic factors. And all of these issues around access and volume and patient population are really talking about, are really kind of, the bedrock of all of this is really structural racism and structural discrimination. Oh, what happened? Okay, sorry. Okay, so in the last little minute, I'm going to take just a few seconds to kind of talk about what we might do. So I showed you the picture of the apple tree, and this is a picture that preceded the apple tree. I really still like this picture too, even though it doesn't talk about justice, just because I think it makes really clear the idea of how we need to start thinking about intervening. Again, in medical education and also in healthcare delivery, I think we get stuck on the idea of fairness. We get stuck on the idea of giving everybody the same thing. If we just are fair, if we're just equal, then we can fix these problems. But the truth of the matter is, and kind of displayed so perfectly in this particular picture, not everybody is going to be able to function with the same tools. You're going to need to think about giving people what they specifically need. And so we have to start to shift our mindset a little bit, to start thinking about what does this particular patient, what does this particular population need. So there's a couple of things we can do. First, it requires us to do work, sadly. But I think that this work is not hard work. I think we've gotten to a place in our society where there's enough material out there that you can educate yourself and you can do that inward work on your own. Here are a couple of examples of things you can start to do. There's a lot of podcasts now. There's a lot of really interesting and engaging books. It requires that you kind of get up to speed with a basic understanding of some concepts. And so these are kind of a good starting place in terms of resources, but there's lots more, and there's a lot of availability of this material. And then we have to get to the bottom of that conceptualization that I showed you, that huge picture that I showed you at the beginning. The driving force of all of this were public policies, the laws that we create in our society, and our social norms, how we feel about people, who we value in society, who we've determined gets advantages in our society, and who we've determined gets disadvantages in our society. So we have to address both of those things. From a social norms perspective, we need to talk about inclusion, equity, and respect. We need to think about enforcing social norms of inclusion and equity, educating or legislating. That's when somebody who violates that social norm, either you help them to understand what is wrong, you educate them, or if they're kind of repeat offenders and they can't really kind of get these concepts down, or if they're more malicious, you legislate. You keep them from interacting with other patients or with patients. You keep them from doing those types of things. Observe and challenge your own implicit biases, and that is active work that we all need to be doing since we all have implicit bias. So that's work that I kind of typically do just as I'm walking down the street. I try to become more aware of what my implicit biases are. And evaluate and break down unnecessary hierarchies. This is work that we can all do in our clinical settings, in our interactions that we have with students, with residents. And then related to laws, this is a little bit of a difficult concept for some people because this is an idea of what are we doing talking about laws when we're doing inguinal hernia repairs. And the idea is that medicine is a social science and politics is nothing else but medicine on a large scale. So if we want to address structural issues, and we said that these individual things are not going to change, we have to go about changing the laws that have created the structures in the first place. So that means we have to think about moving our work outside of our clinical spaces and advocating for policies that address social determinants of health, communicating with elected officials, and forming cross-sector collaborations and community coalitions. So the last little things that I want to leave you with is this idea that of progress, that we've gotten to this moment in time right now where we're making a lot of progress. It's made through the passage of legislation, court rulings, or other formal mechanisms that aim to promote racial equality or equity. But with progress, it's really important to remember that there is always retrenchment. And retrenchment describes the ways in which progress is often challenged, neutralized, or undermined in key policy arenas. So as you start to see progress, you consistently see pushback. If you're not prepared for that pushback, it could be very defeating, very problematic. So it's important to be thinking about that as you're trying to move into this space. And so I always like this quote by John Lewis in thinking about progress and retrenchment, which is, do not get lost in a sea of despair, be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in some good trouble, necessary trouble. And the last thing I will leave you all with is this idea that we all have a responsibility, if we see something, to speak up and take a stand. That is the way that we begin to start to shift these social norms. So this is a quote by Elie Wiesel, and he said, "We must take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. Sometimes we must interfere when human lives are endangered, when human dignity is in jeopardy, national borders and sensitivities become irrelevant. Whenever men and women are persecuted because of their race, religion, or political views, that place must, at that moment, become the center of the universe. Thank you.
Outstanding review, introduction. This is just a story that is the beginning of a conversation. But especially thank you for trying to make it sort of surgical for us. I mean, I do know that there are some implicit biases that people think surgeons are narrow thinkers and that we can't, that we're not very smart and all those other things. So I'm just teasing you a little bit. But no, I think taking the time to help us realize that it happens in our everyday life and what we do is so important. So we've got a minute. Questions? Dr. Mann.
So we have a question from Dr. Humphreys. We continue to see racial differences in amputation rates for patients with diabetes and arterial disease. We found in work that we have done at UC Davis, when we controlled for access to care, there was no difference in amputation rates between racial groups. We also see that Black and Hispanics are less likely to have a procedure to improve their blood flow prior to amputation. Does the health system have focused programs in areas of the city to help patients need better care? And if not, is that something we need to focus on?
That's a great question. I would say yes. So the idea is, I love this question because it's doing what I think we all need to do. It's one, becoming aware, kind of identifying what the inequities are in our system, and then starting to think about what do we do, what is the bicycle that we need for that particular, to fix that particular inequity. So even kind of giving a recommendation there of, okay, here's a step, here's a strategy. Maybe we need to start thinking about partnering with the community to kind of determine some possible interventions or ways to address and eliminate some of the things that are leading to these inequities. So clearly it can be done. And actually, I didn't present that data, but you do see there has been data to support that in some areas, these gaps have been closing. These inequities are being improved in certain surgical procedures. So there are ways to try to address them. Improving access is a huge one, but there's a lot of other interventions that you can do to move forward, and surgeons have been doing that work.
Wonderful presentation, Dr. Shim. Is very enlightening and really opened up a lot of sort of concepts for us to think about. You want to comment on sort of the conflation of race and socioeconomic status? Just to kind of give some story background. My parents are middle class. For African American standards, probably upper middle class. Yet when they have a new encounter with healthcare, the first thing they do is give the clinician my name and my position here at UC Davis and where I went to med school. And in my interaction with their care providers, there's been some sketchy stuff. Also with great misdiagnoses, delay in care, and et cetera. You look at maternal mortality for African American women, which it goes beyond socioeconomic status. I remember when my wife was in labor, there were some issues that were going on, and she likes to say that I went surgeon on everybody, and yet I did, and there are some issues down the stream where I thought, well, what if I didn't? And there could have been really negative effects for my child and my wife. And there was a situation later on with another family where that person didn't have the option to go surgeon on everybody, and there was negative outcomes. So you want to comment on that, the sort of the conflation of race and socioeconomic status.
Yeah, that's a really great point, and you've given great examples, and I think we can think of many more. I think one that comes to mind really quickly is Serena Williams when she was pregnant, and she had complications, and she was not believed initially when she was complaining of shortness of breath. So I think that this is a huge problem, and it's funny because there's this discussion about how in black families you talk to your kids and you talk to your male kids especially about how to interact with the police. One of the things that I have not seen black families doing, which I do in my family, is I instruct everybody who is black in my family who is interacting with the healthcare system to tell their physician who's treating them that they have a physician in their family, that they have a daughter who is a physician, or that they have a cousin, because the standard changes. And again, I'm not accusing anyone of being racist, but there is kind of an idea that you get a different type of care. And so there is this conflating because of those wealth inequities that you see. You do see a larger number of African American and Latinx people with high, and Native American people in particular, and indigenous people with high rates of poverty, and in a country where poverty is kind of demonized and seen as a problem. So there's I think a lot of kind of intersecting issues related to that, and I think I could talk about a lot of different things related to that, but you've highlighted some of the important pieces, and I would just say that that when we're thinking about the interaction between socioeconomic status and race, when you think about the fact that that intersection with, for instance, residential segregation, even African Americans, and you mentioned this idea of like upper middle class versus what is considered upper middle class versus middle class, depends on race. But even neighborhoods, right? So we see, as a result of residential segregation, that white people of a certain income live in highly segregated neighborhoods. Black people of the same income often tend to live in poorer neighborhoods. So you see kind of these stratifications of race and this intersectionality of socioeconomic status. That means that no one of any socioeconomic status is safe in these racial categories. And another example, you mentioned your wife and her complications. I don't have kids, but every single one of my friends who I went to medical school with, who is a black woman, had significant complications with her pregnancy. These are all healthy physicians, all of them. And I did not have one friend that had a smooth pregnancy at all. It was always complicated by something. And so when you start to think about that, I think socioeconomic status does not protect you. Stress and the stress of existing in a structurally racist society has huge impacts on how people's health outcomes are.
Hi. I just wanted to recognize and appreciate the voice that you're bringing here and your bravery for talking about this and for making it such an important topic for us to recognize. I think we probably don't do a great job of educating our pre-med and our medical students and our residents about these issues. Are you aware of the training that the medical students and residents go through, and what can you see as potential steps in the right direction that we can help implement?
That's a great question. Thank you for asking. It's actually a passion of mine. I think we're doing some good things in the medical school to try to mitigate this. And I think that one of the big reasons that we're doing such good work is because the students and residents are really driving this work. So what we see is that all of us, and I consider myself to be in our generation, us older people, we all have come up under a system which was very hierarchical, with this idea that the hallowed physician that was training us knows everything. But this is not something that those physicians had ever been taught. And what I'm seeing now is that medical students are coming into the field having done their undergraduate degrees in critical race theory and anthropology and all of these fields in which they understand this stuff far better than we ever will. And then they take that and kind of meld that into the work that they're doing as they're learning how to be doctors. And so the students have really driven a lot of the changes that we've made in the curriculum to try to bring more of a social justice informed lens to the teaching that we're doing. So we have a health equity course here at the medical school. And we have several folks in the health equity, diversity and inclusion office that are working on trying to expand the curriculum. And there's a lot of new curricula on the horizon in this space. So like a review of the literature, you'll see there's a lot of new kind of attempts to bring these concepts into medical school. But it does require, I think it requires the instructors to have, and the physicians to have a certain amount of humility around what they don't know. And that, I think, is the biggest challenge.
I think you make such an important point, and I remember thinking that I thought it was odd that we had a division of minimally invasive surgery, that I looked forward to the day when all surgery was minimally invasive and we didn't need a separate division. And I find myself thinking, I'm glad so much great work is being done by the Office of Diversity, Equity, and Inclusion, but I look forward to the day that this is a conversation that's just a natural part of how we take care of people, because that's what we do, and that we don't need an Office for Diversity, Equity, and Inclusion.
Exactly.
But thank you very much for coming today, and I really appreciate you starting this important conversation for us. So.
Thank you.